Okay, so next we're going to talk about hepatitis C and HIV and HCV co-infection. So hepatitis, what's the definition? So it's the inflammation of the liver caused by many differing agents, including viruses, alcohol, drugs or prescriptions, herbs, genetic disorder, and also obesity. So the major hepatitis viruses. Hepatitis A primarily is from fecal or oral contaminated food or water. So hepatitis A is a huge problem in developing countries because of the lack of sanitation there. Hepatitis B is primarily transmitted sexually or between mother and child blood exposure. Also with transfusion, intravenous drug users, or IDU, or tattoos by the needles. And then hepatitis C is through blood exposure, transfusion, IDU, tattoo. Sexual mother to child is less common in terms of hep C transmission. So in the United States, 3.7 million people currently are infected with HIV. 60% is due, the highest percentage is due to drug use through needles, IDU. It's a leading cause of cirrhosis and liver cancer, and the most common reason that there's liver transplant in the United States. I remember not too long ago, God, what was his name? Crosby, was it David Crosby? Some famous people, there was some uproar because they move up the waiting list to get a liver. Because unfortunately, if you have a lot of money, then you could get bumped up. And there was definitely some outcry about that. There is 8,000 to 10,000 deaths from HCV annually, and the HCV-related deaths are projected to triple in the next decade. And why is that? Well, the main reason is that, as with AIDS, HCV or hep C can lie dormant for decades. I've worked primarily for years in the substance abuse field, and I remember, clients in their late 40s, 50s, even though they haven't shot up dope since their 20s, were now getting diagnosed with hep C, and like, how could this be, Dr. P? I haven't used drugs in years. But unfortunately, it could lie dormant that long. And then the prevalence of HCV among selected groups. Injection drug users, or IDU, is the highest, 52 to 90%. Hemophiliacs, 60 to 85%. HIV-infected individuals, 9 to 40%. So there's a big overlap between someone who has hep C and also is HIV positive. So if you're working with someone who has HIV or hep C, vice versa, there's a good chance, almost 50-50, that they have the other disease, so it's important to have that tested as well. And then in terms of incarcerated individuals, HIV is 50% or more. I worked at San Quentin State Prison for 7 years until just recently in December. And I think probably 80% of the men on my caseload were HIV positive. So I think this number is actually even higher, unfortunately. And the prison seems to accentuate all of the prejudices that are in our society. So because of the homophobia, that's like even 10 times worse in prison. HIV isn't something really discussed, and is transmitted even more so. because of that. So what's the history of hepatitis C? So again, as I was saying, most patients with chronic hep C are asymptomatic for 10 to 20 years. They have acute hepatitis C, but then it goes to chronic, and then it goes to cirrhosis, and this is where clients end up dying of liver failure or cirrhosis of the liver. So hep C, similar to HIV, replicates in liver cells. I'm sorry, it replicates in liver cells. HIV is blood cells. But it's a similar process in terms of replicating. And the immune system responds with inflammation, and then inflammation could lead to fibrosis and eventually, in some cases, cirrhosis or what's called scarring. Similar to someone who's an active alcoholic in the late stages of alcoholism. Predictors of advanced disease. So person that's infected 20 to 40 years prior, again, remember I was telling you, like, people in the middle age are really hit hard with being diagnosed with hep C. Person with a long history of moderate to high alcohol consumption, and then lab values that suggest someone has cirrhosis. A liver biopsy is an important tool in diagnosing hep C because it provides information in terms of the degree of inflammation, the stage of cirrhosis or fibrosis, and the presence or absence of cirrhosis. And it helps to determine the prognosis of hep C, what's the likelihood the client can recover, and the need for treatment. So treatment, is there a cure? Yes, for many, but not for all. So the main treatment is interferon, and then the next is ribavirin, but interferon is the main treatment for people that have hep C. Unfortunately, there are a lot of side effects with interferon. Again, while I worked at San Quentin, a lot of inmates, in addition to being HIV positive, also had hep C. And while they were on their course of interferon, depression is a huge side effect, to the point where for some inmates, unfortunately, for some men, it was just debilitating. And even with antidepressants, they still just decide, you know what, Dr. P, this is too much. I just, they would get suicidal. I don't want to live anymore. So that's a huge side effect and clinical issue when working with clients who are on interferon. So there's flu-like symptoms, there's headaches, the fatigue, depression. So the psychiatric depression, mood lability, similar to bipolar, brain fog, clients just saying they can't think clearly, diarrhea, alopecia, losing one's hair, nausea. So unfortunately, a lot of nasty side effects. But what's the upside? Get rid of hep C and you're able to live. But it's, I think one of our main goals as a clinician during the interferon treatment is giving our clients hope, because it's a rough road. If you've never worked on a client who's going through interferon, it's not easy to watch. So what's one of our goals is managing the depression. So the first thing is to assess the client in terms of whether or not they have depression to begin with before you even start interferon treatment or before they start interferon. And then confer with the psychiatrist to help stabilize the client on some sort of antidepressant before they start treatment on interferon. And then an immediate evaluation if the client is suicidal. This happened again a couple of times with a couple of men I was working with to do an immediate triage and we had a special unit for clients that were suicidal, similar to like if someone was 5150. So what are some indicators that a patient is ready to start interferon? Their mood is stable, or for the most part, they're stable on medication. They're alcohol-free, and you know, a lot of people don't want to give up drinking. So then you do the harm reduction, or work with them to say, you know what, because I know some clients, not in prison, but outside of prison in my practice, were willing, you know, if I worked with them, okay, could you just stay alcohol-free for the year that you're on interferon? So if you want to go back to drinking afterwards, that's your choice. But how about, can we just look at it for a day at a time for a year? Instead of like, if they went into rehab or AA and then they're looking at, oh my God, I'll never be able to drink again. And a lot of clients just can't grasp the concept of one day at a time. So just short term. Stable housing. Unfortunately, hep C is really a higher incidence with clients who are homeless, or a higher incidence of poverty. And the right time, like they're just ready. In the sense of, I had one client who, he just kept debating it for months and months, and he had two daughters who were like in their early 20s, and he realized the right time for him was, wow, I want to, you know, see them get married, walk them down the aisle, or, you know, whatever their adult life is going to be. He decided, you know what, I really want to be there for that. And that was the right time for him. And if there's other chronic health conditions, make sure they're managed. And part of our role as well is patient education, the transmission, alcohol use, depression, antidepressants, this is huge, and to review with the client their treatment choices. The role of alcohol. So alcohol totally exacerbates hep C. Alcohol plus hep C advances it faster and faster. And recommendation for the person with hep C, there's no safe level of alcohol consumption. So again, ideally you're working with a client who has hep C to abstain from alcohol, period, until they go through their treatment at least and they no longer have hep C, or do some type of harm reduction. So 10 to 30% of patients that have HIV also have hep C. And the rate of hep C also depends on risk factors such as hemophilia, has the highest percentage. Drug users, 70 to 90%, and then men who have sex with men is 5 to 10%. HIV accelerates hep C liver disease, may cut the time to cirrhosis in half. So you could see where a client that has both hep C and HIV really need to get them in treatment for both quickly because of the potentiating effect. Hep C may interfere with immune reconstitution after ART therapy. And hep C may occur at even an earlier stage when there's a co-infection with HIV. Liver disease is more severe in clients that are HIV positive. And then liver disease is now more important because HIV deaths are decreasing. So we really want to focus on the damage of hep C. And the effect of hep C infection with clients who have HIV, the progression is not, though, exactly known. Again, with the liver disease or cirrhosis, it really accelerates it. But in terms of the overall arc, we're not sure. So summary of clients that have hep C and HIV. Someone who has HIV and hep C, the disease progresses faster, and there's a lot of, there's a greater amount of side effects, and possible interactions with HIV medications. So you'll need to work closely with your client's doctor as well.